Yes. First of all, before we begin, I appreciate a lot about residents. And I remember my time when I was a resident, I didn't have the knowledge that he has. This guy is one of a kind. Keep it up, my friend. And you're going to see it. So, David, today is an outpatient. This patient walks in your clinic, and
Yeah.
she's a 47-year-old female. She tells you she has been having joint pains for 3 years.
Okay. Thank you, Joseph, for the introduction. So, because we are going to co-discuss with Michael, I think I'll give Michael the I think I'll let Michael because I've done this a number of times. I would like to learn from him. So I'll leave Michael start, and then if there are some other things that I need to add on top of what he teaches us, I'll do that. So I think we'll do that for almost every early quote. So Michael, if you are good to go, you can start, and then I'll come after you, right after you.
Okay, so, thank you, Dr. David, and I'm humbled to be the first one to discuss in. And okay, thank you, Dr. Joseph Either. So, for the case of 47 years old female with joint pain for 3 years. So, initially to begin with, so it's a middle-aged female, and with joint pain, and look like for the particular duration given is 3 years. So the symptoms that presented more likely to be chronic rather than acute, and so the joint pain is more likely to be chronic. Though, so for joint pain, I will group them into some groups, and one of them will be whether is it an inflammatory joint pain or non-inflammatory joint pain, and they discuss whether from the history whether this joint pain is symmetrical or asymmetrical, because we know there are disease patterns which can present with asymmetrical joint pain or asymmetrical joint pain. And then I would like further to know and understand in particular the progression of the disease. Are the joint pain additive in nature or they are not additive in nature? So that's number two, which will probably point us toward whether this particular female is sick from diseases, and will help us differentiate diseases from inflammatory joint pain, rheumatoid arthritis, and other diseases. And then we want to know further whether this joint pain is it a monoarthritis or polyarthritis. Because if it's a monoarthritis, it will point us toward other chronic diseases, rather than. So for chronic diseases, we'll think of if it's monoarthritis, thinking of reactive arthritis, think of think of reactive arthritis, but this will be most likely for polyarthritis, so multiple joint involvement. So for more likely, if it's polyarthritis, reactive arthritis will be in, rheumatoid arthritis will be in, and other differentials as we discuss along the case. And apart from that, also, we would like to hear if there is any joint deformity in the particular history, since this has occurred for 3 years. So there are diseases which they are more likely to cause joint deformity, such as rheumatoid arthritis. So more likely to have a joint deformities, such as things like botonea deformities and the other manifestations in rheumatoid arthritis. And more than that, for joint pain for 3 years, we would like to know whether this patient has things like associated manifestations or presentations or preceding presentations. For psoriatic arthritis, we probably have things like skin changes, probably if the patient has, and then this will point toward psoriatic arthritis. And so involvement of the joint also is very, very important, whether is it the axial spine or peripheral joint involvement. So if it's axial spine or peripheral joint involvement, also it can help us to narrow down the differential diagnosis. And furthermore, associated symptoms. So do these women has, let's say, intermittent fevers or not? And yeah, I think that this will be a nice start with a joint pain, and probably if we can hear further from the patient.
Thank you, Michael. So I think I'm right there with you. I do not have anything to add. Maybe all I will do is to because I believe we have some newcomers here. So I'll be your translator today, just to tell them some of the, I think, more technical jargon you've used, so they're on the same page. So basically, I'm thinking exactly the same way. So we are talking about a middle-aged female joint pain that is more in the territory of chronic joint pain. So our interest is whether this joint pain is inflammatory or non-inflammatory. And so when we talk about inflammatory joint pain, I think we'll clarify more later. But so when you talk of inflammatory joint pain, rheumatoid arthritis, for example, and other autoimmune diseases will cause inflammatory joint pain. So someone might wonder that isn't all joint pain inflammatory? No, it's not. We know that pain is one of the we say is one of the symptoms, or rather the manifestations of inflammation. We talk of pain, we talk of redness, loss of function, and yes, there is heat, but then pain can be inflammatory or non-inflammatory. So, for example, joint pain of osteoarthritis is not inflammatory; that is mechanical. Although, yes, in osteoarthritis, if you read the pathophysiology, you do discover that there is some inflammation involved. But then there are some things that differentiate it. So, for example, if someone is having joint pain and on examination you see tenderness, that is inflammatory. If someone is having joint pain and then there is color change, that is inflammatory. And if you have joint pain and there is associated stiffness, especially in the morning, and this pain is worse when the patient wakes up but improves with activity, then that is inflammatory joint pain. So that is what Michael's communicating. And another very important thing is the number of joints involved. Is it a monoarthritis, that is one joint? Is it an oligoarthritis? You are talking of 2 or 3 joints at most. But then is it a polyarthritis when you have more than 3 joints involved? So all these are important questions. All I was trying to do is just to translate what Michael was saying. So Joseph, can you give us the history?
Yeah, I like that from both of you. That's a very nice start. So let's see the HPI.
Yes.
So joint pain involves the hands, wrists, elbows, shoulders, knees, and back of the left foot. She also reports that pain in the right gluteal region that radiates to the right leg. The pain is worse during morning hours and it is associated with joint stiffness. She reports on and off swelling of joints of the hands. She has a distant history of low back pain in her 30s, but currently she doesn't have any back pain. So that previous back pain didn't wake up from sleep. The pain responds to NSAIDs, but not to paracetamol. She denies eye pain, eye discharge, photophobia, painful urination, frothy urine, dry eyes, mouth, fever, muscle weakness or pain, diarrhea, abdominal pain. If you have a system, there's no call for shortness of breath. Past medical history, nothing significant. The medications that she's on, PRN, meroxicam, or tabs flama. Family social history, there is no family member with joint pain.
Yes, Michael.
Yeah,
Uh,
yes.
yes, there we have the HPI. So can you go with that?
Okay, so for a 47 years old female, and then now we have a joint pain which involves small joints. We can see that there's a involvement of small joints, and it looks like it's bilateral because it's written hands, wrist, elbows, and then so we have hand and wrist, and then we have elbows, and we have shoulder, knees, and back of the left foot. So the joint pain looks like it involves both small joints and large joints, and so for this pattern of involvement, which is symmetrical, at this particular point in time, I'll put in rheumatoid arthritis top on the list, but then that she's a female of 47 years old and with a chronic joint pain. And so also put pain in the right gluteal region that radiates to the right leg. So this pain from the right gluteal region, so trying to think of involvements of the, or distractions of probably of the bones, particularly in the, at this particular level, the right gluteal region that radiates to the right leg. So pertaining to this, probably there is an involvement of the bones in the pelvic bone, or there's a distraction that probably the nerve is hinged somewhere here. But the joint pain is also was in the morning hours and associated with joint stiffness. So so was in the morning hours. So this one will point toward more of so this patient, once they go into rest and then they wake up in the morning, the joint pain is more severe. So this pain will subside during the day. That's why it was during the morning hours, and with the effects of the joint stiffness in it. So we will ask later on whether this joint stiffness also resolves with time or not. But the pain that was in the morning hours, so point toward more of inflammatory pain, and with a joint stiffness, whether this morning, just during the morning or not during the morning, is it persistent? So if it's persistent, probably we are speaking of a joint deformity at this particular point in time, and the report of on and off joint swelling, so this is pointing toward dactylitis either. So this is confirming the presence of an intermittent episodes of inflammation. So this is more likely to be an inflammatory joint pain. Up to this point in time, I'll put my coin on the inflammatory joint pain. So the distant history of back pain at the 30s, but none currently didn't work up for, so, and the pain was not that much severe. So the scale at that moment was minimal scale. But the low back pain, so with low back pain in 30s, so this now will raise another concern, probably of an axial nature, because with the low back pain, so low back pain plus the current presentation is not entirely with this, but the low back pain and the right gluteal regions pain, this point toward also spondylitis. So thinking of an axial spondylitis, but with the current presentation and involvement of other joints, so I'll put this second to inflammatory joint pain, which initially would have rather thinking of rheumatoid arthritis. But with the low history of low back pain in her adolescence, I'll put pointing toward more the presence of, probably we are dealing with an axial spondylitis at this particular point in time. And so the pain was responding to NSAIDs, which is responding more and showing that this patient has inflammatory joint pain and not to paracetamol. So the inflammation was controlled by non-steroidal anti-inflammatory drugs. So with no eye pain or discharge or photophobia, so trying to rule out anterior uveitis and the other manifestations that come together with axial spondylitis. So axial spondylitis specifically in this particular case, if we want to discuss one, it will be the ankylosing spondylitis. So for which in ankylosing spondylitis, you have back pain, and patient might have a gluteal pain also, and presenting with either of the uveitis. But this patient has no eye pain, discharge, or photophobia. So trying to saying that the ocular manifestation, which goes together with some diagnosis in a patient who presented with a chronic joint pain is out. Rather, even in rheumatoid arthritis, some patients also present with ocular manifestation, and they have scleritis and other manifestations. And they can also have uveitis, but it's more specific for anterior uveitis for patients with ankylosing spondylitis. So the patient also has no painful urination, froth urine, and dry eyes or mouth. So dry eyes or mouth, also trying to rule out some other autoimmune conditions that might present with joint pain. So we have such things like lupus arthritis, of which they can present with joint pain and they can be chronic, pertaining that, and keep in mind this patient is a female, a female who is around 30s. So the initial presentations were around 30s. So the power of an autoimmune arthritis cannot be ruled out. But other symptoms that will suggest probably this patient has an autoimmune arthritis, such as lupus arthritis and others. Dry mouth is out, and also the ocular manifestations are out. So muscle weakness or pain is also a very important clue that will lead us to rule out some other presentation. So for other connective tissue disease that can present with also joint pain. So there are connective tissue diseases. So for this, they can have also a muscle weaknesses, or a muscle weakness also can come from the complication of the particular disease that is going on. Keeping in mind that she has been sick for 3 years. So if you have a severe joint deformed, we can have a muscle weakness from that particular moment, from that particular region that probably the nerve is injured, or where the nerve is injured or is impinged. And then the patient has no diarrhea or abdominal pain. So diarrhea or abdominal pain also comes with some diseases that might present with joint pain. So one of them is reactive arthritis. So for reactive arthritis, depends on the particular infections, but regarding the chronicity of the presentation, so for 3 years so for this chronicity, I will not put much on the reactive arthritis. So ruling out abdominal pain and diarrhea was very important. So to this particular point in time, I will think of, so this joint pain is more symmetrical. So it's symmetrical with the involvement of both small joints and large joints. And with the first presentations at nearly 30s, ankylosing spondylitis will be in, with the presentation that this patient has a gluteal pain, so has a right gluteal region pain that radiates to the right leg. So I will put in ankylosing spondylitis with this presentation, though the other presentation that does not tally exactly with the ankylosing spondylitis, with the involvement of the symmetrical presentation of other joints. So this is less likely to be there in the ankylosing spondylitis. So I cannot recall clearly, but up to this point, I think if we score this patient into the criteria for rheumatoid arthritis, he will fit in for duration is more than 6 weeks. I cannot clearly recall the criteria, all of them, but duration is more than 6 weeks. That's number one. And number two, there is involvement of small joints. If we count them, I'm not sure how many, but hands, there are so many joints over there. Wrist, and then we have the elbow, and then shoulder, knees, and back of the left foot. So with these involvements and patterns, I think in that particular criteria, someone will remind us, probably in comment, or Dr. David will comment on it. Rheumatoid arthritis will be in. I'll put a coin in that particular region, and I suspect probably this patient since the patient has joint stiffness, probably we have a certain joint deformity. Probably you see that in the musculoskeletal examination, and decide which the joint deformity is present. And so the thing that I will put second in the diagnosis will be ankylosing spondylitis, because sometimes disease probably can present in both aspects, whether this patient has an ankylosing spondylitis initially, and for ankylosing spondylitis, the initial presentations are, so first of all, age will be around 20s to 30s. And the other thing that is they have gluteal pain. This can be one of their presentation. So with this particular patient also, I'll think of ankylosing spondylitis. So the thinking of a lupus arthritis or an autoimmune arthritis to this lady, to me, it's less likely, but it's possible. So I should not ignore that possibility. It's less likely, but it's possible. So welcome, Dr. David, for addition.
Well, you have left nothing for me to discuss, my friend. So I think everyone can see Michael is rendering me jobless today. So I'll just translate on again, just to repeat what you said. So yes, we are dealing with. So for those who joined late, we are discussing a case of a 47 years old female who presented with a 3 years history of joint pain. And when Joseph started presenting the HPA, we discovered that this patient is having what seems to be symmetrical. asymmetrical polyarthritis, because there is involvement of both hands, wrists, elbows, shoulders, knees, as well as, so there's one thing that I need to point out here. So in Joseph's first bullet, that there's also pain involving the back of the left foot. So what this could mean, the back of the left foot. So if you look at that place, it's either that you are talking of a bone at the sole, or another thing that you are talking about is what we call enthesitis, when you have inflammation of a tendon. So that's one of the assumptions that I make, that the pain at the back of the left foot is probably enthesitis, which comes with some of the diseases that Mike has been discussing. And then the pain in the right gluteal region, of course, I have the same thinking. We're either talking about sacroiliitis, or if we are not talking of sacroiliitis, because this pain is also radiating, we could be dealing with radicular pain. So when you have involvement of some bones in the lower spine, especially in the lumbar or lumbosacral spine, where the nerves that supply the lower limb are originating, you could also have compression of a nerve root or plexus, leading to this kind of pain that Joseph is describing. Now going back to so basically we are dealing with asymmetrical polyarthritis, but then with some additional features like possible enthesitis, possible sacroiliitis. But then coming to this lower back pain that Joseph is talking about, there's distant history of lower back pain, and maybe Joseph could have told us more about this. But when you talk of back pain, again, it's important to clarify whether the back pain that we are talking about is purely mechanical, which is very common among young people. It can be due to a muscle strain, and the pain lasts for a short time, or it can be if you have lower back pain that lasts for more than 6 months. Back pain that is worse during the night and that wakes up the patient at night. Back pain that is worse in the morning, improves with activity, or yes, so there is that warm-up phenomena. The patient wakes up and then they are very stiff, but then after a few activities, the back pain gets better. Again, you are talking about inflammatory back pain. Now, Joseph tells us that he did not wake up the patient from her sleep, but he didn't tell us about the duration. So we can try and make some assumptions whether it's inflammatory back pain or not. But then this could be significant. So we should consider a possibility of talking about an overlap between lower back pain, which is started in her 30s, and of course these inflammatory lower back pains that we talk about are between those ages of 20s and 30s. And then the pain of this patient is responding with NSAIDs. So yes, right there, I have absolutely nothing to add. So basically, rheumatoid arthritis is one of our possibilities, but then we should also consider the possibility of a spondyloarthritis. So Michael talked about a possibility of an axial spondyloarthritis. We have others. So there's a axial spondyloarthritis, like when you talk of ankylosing spondylitis, but we also have peripheral. We also have a peripheral spondyloarthritis. So like in this patient, a possibility of a peripheral spondyloarthritis should also be taken into account. So dry eye, dry mouth, things like Sjogren's syndrome can present with joint symptoms on top of the Zika syndrome. And then muscle pains, muscle weakness in particular. Inflammatory myopathies like dermatomyositis, polymyositis, probably ruled out in this patient. And of course, Mike has talked about a possibility of reactive arthritis. So when you talk about an antecedent history of diarrhea, abdominal pain, or painful urination, which signifies an STI that later on presents with reactive arthritis, which is not a possibility in this patient because more commonly a reactive arthritis is something acute. Although yes, there has been a reported history of patients with reactive arthritis that has taken a more chronic course, but then they are more of monoarthritis or oligoarthritis rather than a polyarthritis. So right there with Michael, rheumatoid arthritis, but then a possibility of a spondyloarthritis, peripheral spondyloarthritis being one of the possibilities because of this enthesitis, the sacroiliitis, and the back pain that we have not very much clarified on. So we see the review of systems is unremarkable. You know, some of these diseases that we talk about can involve the respiratory system, for example, with interstitial lung disease. When you talk about the genitourinary system, for example, lupus is one of the things that Michael has talked about. Can lead to renal dysfunction, but again, rheumatoid arthritis can do the same. We have not heard about skin changes or nail changes, hair changes. So because Joseph did not mention them, we can make an assumption that there was nothing wrong with them. But again, Michael talked about psoriatic arthritis. So you could have something like pitting of the nails that gives a clue in that direction. So I think nothing very significant from other components of the history. So Joseph, if you don't mind, you can take us to the physical exam.
Yeah, yeah, sure. Uh, nice discussion. Very nice to have two of you. Yeah, so let's see the exam. The general exam was generally normal. She was alerted oriented, a febrile, not pain, not jaundice, no lower lymphedema, and didn't have lymphadenopathy. Vital signs within normal limit. Of importance, musculoskeletal system exam. She had tenderness and swelling of the left first, third, and fourth proximal interphalangeal joints and distal interphalangeal joints. She also had tenderness and swelling of the right first distal interphalangeal, tenderness and swelling of the left Achilles insertion site. She also had the disfigured right second distal interphalangeal joints. The rest of the systemic exam was completely normal. I think you should discuss this.
Yes, Michael, there you go.
Yep. So to start with the general exam. So with the general exam, this sorry Joseph, yeah there. So with the general exam, so we have nothing significant in this particular point in time. So confirming that the history that was given probably, so most likely from this point in of general exam, the most like things that I was much interested was one is examination, the ocular examination, if it was okay. So to this point in time means everything is okay. So the uveitis is confirmed and now ruled out. So it's not in at any point in time. And then the hairs and nails examination, I hope also it's okay at up to this point. So I will drop things like psoriatic arthritis. So of which, if we think of psoriatic arthritis, so initially I think I overlooked this one. So it needs at least, if I'm correctly, 10 years from the initial presentations of skin changes or nail changes to the presentations where the patient will present with psoriatic arthritis. So the initial presentation was at around 30s and then to 47, around for 17 years. But with this general exam, I can say probably I will drop psoriatic arthritis to this point. And then the vital signs were okay, were very fine. So this signifies probably do not have any other complications pertaining to the disease. So on systemic exam, it looks like this patient has the inflammation was ongoing. So as far as it will say on and off joint pains and swelling. So we have dactylitis at this point. We have tenderness and swelling. So we have dactylitis, and then we have the left Achilles, also the right first DIP, and left Achilles insertion site. So enthesitis is in. So thank you, Dr. David. I forgot the word enthesitis. I can agree that I forgot the word enthesitis initially. So the left Achilles tendon insertion site was also inflamed. So we have dactylitis, we have enthesitis, and we have disfigured right second distal interphalangeal joint, signifying, so this disfigurement was not described so that we can point whether so it's the distal involvement of the joints. So is it disfigured in which part, and then to say whether it's a bottleneck deformity or any other deformity that comes with rheumatoid deformity, or is it a piano deformity from rheumatoid arthritis? So I'm not sure, but this signifies that we have a joint deformity. So a normal systemic exam to these patients, respiratory exam is normal, so I will comply with what Dr. David said, that we do not have respiratory manifestation or complications from these chronic diseases such as rheumatoid arthritis, which comes in with interstitial lung diseases and others. And the cardiovascular also, it's normal. So having a normal cardiovascular exam in this point is pointing toward that if I put my coin on rheumatoid arthritis, one of the things that I will be interested in cardiovascular exam is aortitis. So this patient also always have aortitis. So if it's okay, means that complication is also ruled out. And with the normal abdominal exam and neurological exam. So normal neurological exam also is very important, particularly in making the diagnosis, ruling out the complication, and also assessing the prognosis. Because having a normal neurological exam looks like if you have a disfigured joint, DIP, the distal interphalangeal joint, it's disfigured. So you have a joint deformity, but it's not that much severe enough to cause a neurological deficit or any neurological abnormality. So we don't have things like the patient does not have a loss of sensation to that particular region below the joint that is affected, which is a very important marker in the management and also in the treatment and management of long-term complications of this patient. So up to here, as far as we have an inflammatory, a 47-year-old female with symmetrical inflammatory polyarthritis, mostly involving small joints. So the involvement of the small joints have dactylitis and enthesitis, and also have joint deformity, hardly to point to which joint deformity, with other systems, systemic examination being normal. So I'll put my coin more likely on the rheumatoid arthritis. This will be top on the list. And the other thing that I will not drop it by 100%. Number one will be I will not drop by 100% as a possibility of psoriatic arthritis until it's proven otherwise. And so for axial spondyloarthropathies, I think up to this point in time, it's down in the list of my differentials, or else until we go to investigations and the other things which will whether they will tell or not. And welcome, Dr. David.
Thank you very much, Michael. So again, I thank you very much because you are giving me direction today. So I'm just following in your footsteps. So with the physical examination that we have, so basically, I think we are in the right neighborhood. The main issue that we need to do right now, or even if we get lost, at least we are sure that we will not be lost very far. At least we'll be lost in the neighborhood. So of course, what we are trying to do is not to be lost in the neighborhood, to arrive at the correct address. But basically, generally, we are in the territory of an inflammatory arthritis. Now, with in the history, it was very clear that we are dealing with something that is bilateral and symmetrical, involving small as well as large joints. But then coming to the physical examination, we see that there are typical features of inflammation, that is tenderness as well as swelling, which seems to be a little bit asymmetrical, because you have involvement of the left first, third, and fourth proximal interphalangeal joints, and then as well as the distal interphalangeal joint. And then on the right, we have involvement of the first distal interphalangeal joint. And then we have enthesitis, and then a disfigured second distal interphalangeal joint on the right. So not so much of symmetry when we come to physical examination, the current presentation. And it's the small joints that are involved. And Joseph did not mention anything about the back, whether maybe on palpation of the back, if this patient had a tenderness of the back. So with this, I think I also have the same thinking based on the history now that, of course, we cannot throw out rheumatoid arthritis. But then another thing that we need to consider is the possibility, because Joseph has not told us anything about the back, including tenderness of the back. Therefore, if we are talking about a spondyloarthritis, then we are talking more of a peripheral spondyloarthritis. So I think that is where those are possibilities, and that's why I'm saying we can get lost, but get lost in the neighborhood. So basically, rheumatoid arthritis, spondyloarthritis, more the peripheral type, because on the axial, we see more of peripheral joint involvement rather than back involvement. So I think those are the possibilities that we have for now. But then, if we step back and think, okay, what if we are wrong? It's not rheumatoid arthritis. It's not a spondyloarthritis, more a peripheral type. What are we dealing with? So, of course, with the history and then the physical examination that we have, I think those are the possibilities. And then, of course, we could be wrong. We should be open to the possibility that we are wrong, and so Joseph will teach us. So that's what we have for you, Joseph. Maybe let's hear the labs and any imaging that you have, and then maybe we can make some progress.
Yeah, sure. So I think you're in the, the right line, and let's see the labs now. So the labs were remarkable. She had the normal white count, HB was normal, platelets normal. ESR was 30, the machine is 0 to 30 is normal. RBG was normal. Urine analysis, the only a proteinuria of +1. It was an afternoon urine. Rheumatoid factor was negative. I received it later, was also negative. And the creatinine urea was normal. You look at that left foot on your left side with the enthesitis, and that's how it looked like. I don't know what you're seeing, but I saw it as normal. So then I had to image her hands. They're also normal, like the way you're seeing it here. It was the left hand, the one which has a deformity on the DIP. So yeah, that's what we have.
So okay. So thank you, Dr. Joseph. So to start with the investigations that has been detailed, probably detailed done at this point in time. So the WBC is normal. Also trying to rule out some other possibilities and also complications. So, but I was interested with few of them, and Dr. David will comment on the others. So ESR, and I was also interested with rheumatoid factor and the anti-CCP at this point in time. So rheumatoid factor and anti-CCP, they are all negative. So trying to rule out the possibility of probably we have a rheumatoid arthritis, but I think another possibility that is very important to recall, I'm not sure, stand to be corrected. I think rheumatoid factor has a sensitivity of around 70%. So I'm not sure. So we can go. So it's not 100% sure that if you have a rheumatoid factor negative, that means the patient does not have rheumatoid arthritis. And also, if we have a rheumatoid factor also negative, there is a possibility of another possibility of seronegative rheumatoid arthritis. So we have a seropositive and seronegative rheumatoid arthritis. So with the TCCP negative, so the possibility of rheumatoid arthritis is also a bit not that much. It's not convincing that we have a rheumatoid arthritis, because I think anti-CCP is on the score, on the criteria, the EULAR criteria. I cannot recall them clearly, but the EULAR criteria, they have like, I think four categories. So involvement of the joints and the others. So in the part of investigation, I think anti-CCP is there, and it carries weight either in the scoring. So I cannot recall whether it's 1 or 2, but it's there. So buying it negative if we rely on the physical examination findings and counting the small joint involved, and to see whether the patient will fit in the EULAR criteria for rheumatoid arthritis or not at this point in time. So I am not sure if someone can score, or Dr. David will help me to score the patients and see whether this patient will fit in the criteria to diagnose whether the patient has a fits for rheumatoid arthritis or not. So having a normal creatinine and BUN also will help us in ruling out the differentials, and also ruling out some other diseases that probably we did not think initially, and this will be very important. Some sort of like a cryoglobulinemia and others, which can also comes with joint pain, and so with the enthesitis on the left foot X-ray and a bit of a calcaneus spur. So enthesitis is vividly with probably I think there's edema there, collections of with the blackish pad. So enthesitis was really vivid. So to this point, before going to the X-ray of the hands, I think with the history, the asymmetrical nature that thank you to Dr. David that noted that asymmetrical nature. So the history, initial presentation age, which was 30, 47 years with this some sort of presentation which looked like symmetrical during history, but during physical exam it was a bit of asymmetrical. So having asymmetrical presentation with the involvement of small joints, and at the point of examination, we did not hear about large joint involvement. So psoriatic arthritis and rheumatoid arthritis to this point, to me, carries more weight to this point. The other X-rays of the left hand, it's not clearly seen, so I cannot comment. Probably we rely on the radiologist who reviewed the X-rays and the findings. It's not clearly seen. I cannot comment whether the small joint of the first, second, the third, and the fourth joints are they. Do we have a joint fusion over there? I cannot comment because probably of quality. But for sure, Dr. Joseph has seen the X-rays, so we'll rely on you probably to comment on this or the radiologist reports. So to this point, I should not commit to a diagnosis very fastly, but seronegative rheumatoid arthritis vis-a-vis psoriatic arthritis pertaining to the initial presentation of age, the asymmetrical nature that we have seen in a physical exam, and a 10 years gap presentations, which was 30 years to 47 years. So rheumatoid arthritis is more likely to be in. And I will ask Dr. Joseph, are this the only investigation that were able to be done?
Yes. Yeah, those are the only investigations that I did. And no radiologist. Okay. I am the radiologist. I saw these X-rays now.
Okay, so the X-ray is normal. So I'm happy to hear that the X-ray is normal. So so the deformity or the disfigured finger that we saw in the physical exam, with this disfigured the right second distal interphalangeal joint was disfigured during the physical exam, and this was the left hand. So the right hand, I think the X-ray was not there.
Yeah.
If I'm correct.
Sure, you are right.
Okay, so the joint deformity that we cannot confirm whether we had a joint deformity or not, of which joint deformity, the most common presentations to patient who has a rheumatoid arthritis. So for rheumatoid arthritis, it's common that to have a joint deformity. So to this point in time, I will put my coin firstly a bit reverse. One, I will start with psoriatic arthritis, and then a rheumatoid arthritis will be down the list. Dr. David, welcome.
Thank you very much, Michael. So Again, I'll just backtrack on what you said. So, Joseph, can I see the slide on the labs? So, again, as you very correctly said, so when we talk of of rheumatoid factor, depends on what literature you are reading, but you'll find that most they will tell you that the sensitivity of rheumatoid factor is around 75 to 80%. So that means you have at least 20% of patients who will have rheumatoid arthritis and a negative rheumatoid factor. We are not very disappointed that anti-CCP is negative. Anti-CCP is less sensitive, is not as sensitive as rheumatoid factor, but it's very specific for rheumatoid arthritis. So if someone has a clinical presentation that is in keeping with rheumatoid arthritis, and then you order anti-CCP, it comes back positive, you have much more confidence that you are dealing with rheumatoid arthritis. But again, just a reminder, you should send these autoimmune markers only when your suspicion of a particular diagnosis is high enough, because it's not unusual to have something positive in patients who are completely healthy, or at least not suffering from the disease you are thinking about. And that becomes even more common as people age. So if you are not suspecting SLE, do not send anti-double stranded DNA or an ANA profile if you are not suspecting it from the clinical presentation. Now, so that's it about the rheumatoid factor and the anti-CCP. And then inflammatory markers, not very much elevated. So I'll just try and piece out some thoughts. We have a 47 years old female. The presentation in the HPI, we very much thought that we are dealing with a symmetrical polyarthritis. For sure, we are dealing with an inflammatory arthritis. Coming to physical examination, we see that the patient has inflamed the joints because there is pain, there is swelling, there is tenderness. It's not just subjective pain, there is tenderness. And then there is joint swelling, and there is enthesitis, and there is even deformity of one joint, but then it's not very symmetrical. And one thing that is common in patients with rheumatoid arthritis, when rheumatoid arthritis is not diagnosed and treated early on, it's very destructive. So when you see the X-rays of joints that have been afflicted by rheumatoid arthritis, 3 years down the line, or more than 3 years down the line, more commonly, you would see tremendous amounts of destruction. So we do not see that in this patient. Of course, I think the resolution of the hand X-rays is not that much for us to appreciate, but then we'll take Joseph's word that the hand X-rays were normal. So if we do not see that much destruction, then we probably take rheumatoid arthritis with a pinch of salt. So there is asymmetry on physical examination. You have small joint involvement, but not so much symmetrical. And then inflammatory markers not elevated. Yes, it's not a must, but then for something like rheumatoid arthritis or SLE, you have active inflammation on the joints. We expect the inflammatory markers to be elevated, at least most times, not always, but most times, because there is ongoing inflammation. So no proper symmetry, inflammatory markers not elevated, rheumatoid factor which is fairly sensitive, negative, and then anti-CCP which is very specific for rheumatoid arthritis, negative. So the absence of symmetry, all those features that I've talked about, not to repeat myself so much, I think that reduces my confidence in rheumatoid arthritis. And then, although yes, as Michael said, we cannot completely throw it away. So that leaves me with so on top of psoriatic arthritis that Mike was mentioned, I think another diagnosis that stands out for me is a spondyloarthritis. I think I might be using terms very loosely here, but we have a broader umbrella, which is spondyloarthritis. And then you go in there, that's where you'll find psoriatic arthritis, you'll find ankylosing spondylitis, and then you will also find a peripheral. I'm not sure if we call it peripheral spondyloarthritis or any other term, but peripheral is the key word there. So that is one of the diagnoses that I'm considering. So another thing that I would love if Joseph would have done is x-rays of the pelvic x-rays for us to appreciate whether there is sacroiliitis or not. So that's an extra. I know another thing is because with these spondyloarthritis, we either talk of radiological or there's the radiological subtype where you see the sacroiliitis is very evident, and then the patient is having typical manifestations. But of course, what I'm talking about could also be easily confused with an axial spondyloarthritis like ankylosing spondylitis. But then another thing is you have HLA subtypes. I think that is DRB or DQ something, which comes with the spondyloarthritis. So I think that is the one that stands out for me. And then the others come down on the list. I think rheumatoid arthritis at the bottom of the list at this point. So Joseph, I think we've already committed, unless you have another investigation or another pointer. We should finish, and then you give us the teaching points, because I see Okta, who also sees many of these patients, and I saw another hand. So I think we have many more people who need to teach us today. So
Yeah.
if you have anything else.
But I have to ask one thing. So the involvement of both DIP, PIP, enthesitis, and larger joints, how does this change the possibility of rheumatoid arthritis, the seronegative rheumatoid arthritis?
Okay, so for that one, I mean, small joint involvement is something that we take it as I wouldn't say pathognomonic, but then increases confidence in rheumatoid arthritis. But then it's an issue of symmetry. So enthesitis, of course, that's why I said it's very possible to be lost in the neighborhood. Because I've talked about rheumatoid arthritis many times, but then I would need to go and review my notes, whether it's also common for rheumatoid arthritis to present with the enthesitis. I think it's possible, but then enthesitis is very much more common in the spondyloarthritis. I think more common than in rheumatoid arthritis. So
Sure.
I would need to review that, but small plus large joint involvement, if symmetry is very prominent, then rheumatoid arthritis is a huge possibility.
Yeah, sure. So, as I told you, the anti-CCP was done later. So, as you're telling this patient, you should also go and do this anti-CCP and bring it back. She tells you she also needs an antifungal remedy for her rash. And so you're interested to see the rash she shows you. She says it has been there for 1 month. It is itchy. Um, it is worse when she's in hot temperatures, and when it is cold, it is okay. So she was told it's a fungal infection, and she needs the antifungal remedy. You ask her if she has any other rash. She shows you again. She has it here, another rash, and yeah. So what does that do for you?
Michael, this is your thing, my friend. There you go.
So
Hello, Michael.
We are just finishing up. I think after we Mike meets Joseph presents the points, we'll have some minutes for you all to chip in.
Thank you, thank you, thank you.
So, Dr. Joseph, can we see the first picture, please?
Sure. Do you see it?
So, yep. So hope. Okay, it's now a bit clear. So hope the rash presented is the one that is just below the patella.
Yeah.
And not the other skin lesion that probably I see above the patella. Looks like, I don't know, it's a whitish. I don't know whether they are macules, but they are whitish. So the one below the patella look like it's raised. And for how long has it been there?
1 month.
1 month only.
Yeah.
So with this pattern, I don't know if you can characterize it for us, but I can see it's a bit a purplish, raised, and I cannot comment further because this is a visual picture. But to me now, up to this point in time, I think I will put my coin on the psoriatic arthritis, and with this presentation and the asymmetry nature, enthesitis, dactylitis, a bit of sacroiliitis, whether it's there or not confirmed by via X-rays, and the involvement of both small and large joints with those presentations that I've mentioned, I think I will commit straight to this case for psoriatic arthritis without wasting further time. Dr. David Karibu.
Thank you, Michael. So right there with you. So like I said before, what we see are based on all the pieces that we have put together. More of these are spondyloarthritis, psoriatic arthritis being one of them. So with this rash, that of course Joseph would yes, if you look at this, although it's not very flourished like what we see in many patients with psoriasis. So I think it's that's on top of the list. I mean, we're dealing with and thank you, Antimon, for the term, the extraaxial spondyloarthritis. So with this kind of rash that we see here, yes, on top of the list, psoriatic arthritis.
Sure. And yeah, you guys are right. But I did this purposely to bring this at the end because the patient didn't say anything about the rash until at the end when she was asking about the antifungal medication. And another thing is that I put the history before because maybe you could have seen this patient before these two rashes. She had also another on the scalp, but on the scalp it was even before this on the knee. So you can see this, and then the rash comes later. You can still diagnose psoriatic arthritis because of the involvement, as you're saying. Rheumatoid arthritis shouldn't affect the DIP. That's what my understanding. If you see DIP, question the diagnosis of rheumatoid arthritis. So yeah, I think I'm right. I'm right there with you. This was psoriatic arthritis, and some few teaching points. A lot have been said by you guys, and we are above the top of the hour. This is an inflammatory joint disease, which is associated with psoriasis. The epidemiology equally affects female and males. 14 to 31% of psoriatic patients are affected. So usually psoriasis precedes arthritis, as Michael said. Maybe 7 to 8 years after the onset of psoriasis, it comes the arthritis. But in 7 to 15% of patients, the arthritis precedes psoriasis, like in this patient. So it was an opportunity. If I found this patient a year before, maybe it would have been hard. I would have termed maybe peripheral ankylosing sponge, probably. The labs usually are non-specific. You can send an ANA, rheumatoid factor, anti-CCP can be positive in minority of patients. ESR, the white count can be raised in a third of patients. No wonder this patient they are normal. And the presentation usually fatigue, morning stiffness, asymmetric distribution. So when this patient come, they say there is pain in my hands. So when you go to examine, is where you see what do they mean, because it's not the whole hand. The whole hand has a lot of joints, DIP, PIP, and the others. And so distal interphalangeal joints and spine are affected in 40 to 50% of patients. And enthesitis, tenosynovitis, dactylitis are there. There also skin and nail disease. It's unfortunate I didn't look at the nail of this patient, and maybe if she comes back, I'll look at it, because she'll come for clinic. So treatment, you just give NSAIDs and you start DMARDs. I started her on methotrexate, but other medications can be used if this phase, like TNF inhibitors, not available and expensive, JAK inhibitors. But of importance, avoid the steroids. It's so easy to jump to steroids, but you should avoid it, because if you give this patient of psoriatic arthritis steroids, there is a risk of flare. Yeah. So nice discussion. I loved it. Very nice, Michael. Kudos to you, David. Very nice.
Yeah, so Michael, I'll leave you to go with the reflections first, because all this was your work. Karibu. So we'll reflect a bit, and then we'll give Okta and others an opportunity to speak.
Okay, thank you, Dr. David and Dr. Joseph. So to the case of today, one of the things I think that was a big clue, and it came out later on during physical exam, if not the late during discussion of the history and presentation, which is very important to patients who present to clinics. As Dr. Joseph said, a bit of clue was in the history. At the moment that the patient reported back pain at 30s, and another presentations of this multiple joint pain that we saw, and we thought it was more likely to be symmetrical, was at around 47 years. So this gap was the most important gap, I think, on this side to me, because at this point in time, we are supposed to know whether the patient is suffering of psoriatic arthritis or not, and questioning the symmetrical nature, which came out to be revealed in the physical exam. And the other reflection that was very important from this case to my side was what the patient presented looks like symmetrical, but during physical exam, I actually can confess that I missed, or I was a bit, probably, I was anxious to see, there's involvement of both joints, but their symmetrical nature was very important to be noted. So this gives a reflection of physical exam, not relying on what the patient has said particularly. So examining the patient at this point in time was very important to note their symmetrical nature and the involvement of the DIPs, because as Dr. Joseph said, DIP's involvement is less likely to be in the rheumatoid arthritis. So it's pointing toward other forms of diseases, more likely psoriatic or extraaxial spondyloarthritis. So the other thing that was very important is the rash. So I think in the review of other system, or we would rather ask the patients in multiple issues. So sometimes they will not mention, but it is our task as the clinicians to know and understand that, probably this should be the cause. Because linking the dots, I think if the patient is in front of us, it's a bit hard to link the dots. So thank you, Dr. Joseph, and kudos to you that at last you went on and then realized this rash plus the joint manifestations is pointing toward more likely to be is pointing toward a psoriatic arthritis rather than a rheumatoid or any other arthritis mentioned earlier. And lastly, I would like to thank the chat box for those who commented. Thank you very much for the comments, and I hope we all learn together. And thank you, Dr. Joseph, for the case either.
Thank you very much, Michael. So, and thank you for being a trailblazer. So I hope other people have seen that it's possible to discuss a case, and maybe so next weekend Joseph should just discuss a case to you. You will discuss independently, so we can all learn from you. So just a few reflections. So number one, again, to repeat on what you said, I said this a number of times. There's a lot of uncertainty in diagnostic reasoning, and sometimes we can be very much tempted to fall into the bias of premature closure, which can be very common. You know, we use that term because if you were seeing this patient not with an open mind, you have this preoccupation that you are dealing with, rheumatoid arthritis, it would be very easy to say, okay, patients don't read books. But again, I remind you, if you say patients do not read books, you have to ask yourself first, how many books have you read? Yeah, so because it would be very easy to say, okay, we are dealing with rheumatoid arthritis and then miss the bus. So Joseph was very keen, take history over and over again, examine the patient. It's an iterative process. You go back and forth when things are not adding up. You see, it would be very easy for us to be lost in the neighborhood if Joseph did not mention. Although, again, I commend Michael very much because he was the one who kept bringing up this differential of psoriatic arthritis, because all I had was an extraaxial spondyloarthritis, which of course includes many of these, but then I did not mention psoriatic arthritis specifically. So thank you very much.
Yeah, Okta, karibu.
Hello.
Yes, Okta, we can hear you.
Okay. Thank you very much for this opportunity. And bravo to Dr. Michael. The presentation was really a textbook presentation, the way he was flowing. Actually, I wanted to add some few. In this context of autoimmune disease, when you get one, you need to exclude the others. Usually they do overlap, but one would be predominant. So congratulations again to Dr. Michael, the way he has been ruled out other autoimmune diseases. But again, I wanted to add some few comments on the examination part, particularly on the swelling on the fingers. Actually, we have a deformity in the rheumatoid arthritis, what we call swan-like deformity in the Boutonnet. But again, we have nodules in the osteoarthritis. We have nodules, which is very important to know them. We have Bouchard nodules and Heberdens nodules. So we need to be very sure those deformity or swelling are they not nodules or just a deformity? Because with osteoarthritis, there are very specific nodules which they have. There are Bouchard nodules which they occur in the proximal part, and the Heberdens nodule which occur in the distal part, in the PIP and the DIP. So when we get the patient with nodules in the ends, we need to be very sure which one are they. Are they for rheumatoid arthritis or for osteoarthritis? Another thing which I wanted to emphasize when you get the patient with the joints deformity, apart from concentrating with the just joints, we need to go to extra-articular complications, the way Michael has been elaborated. But again, in the cardiovascular examination, actually for example, ankylosing spondylitis, we have what we call 7 A's as a complication, as extra-articular complications. One, anterior uveitis, which has been well presented, and then they usually present with atlantoaxial subluxation of the atlas and the antral in the cervical spine. But again, they present with apical lung fibrosis. So we've mentioned interstitial lung disease as complication of rheumatoid arthritis. But again, even ankylosing spondylitis do present with the apical lung fibrosis. So we need to keep it in mind. But we've said we've done cardiovascular complication, ruling out aortitis. But again, even ankylosing spondylitis is complication in the cardiovascular, AV node block and the aortic regurgitation. Among the things which we need to rule out. So when we get the patient with joints complications, we need to go deep into extra-articular complications. In X-ray, ruling out psoriatic arthritis, we have a sign in the hand. When we do the X-ray of the hand, we have what we call pencil in the cup. pencil in the cup. It's a very clear sign. When you do X-ray, it is very visible. Though in this X-ray, there's no pencil in the cup, which is very specific to a patient with the psoriatic arthritis. Also, X-ray of the patient with osteoarthritis, we have some features which we can see even if we are not a radiologist. One of the big feature we can see is loss of joint space. Abbreviated by the word loss itself, LOSS. L for loss of joint space, O for osteophytes, S for subchondral cysts, and another S for subchondral sclerosis. We as physicians, at least, we need to look for loss of joint space in the X-ray of the patient with the osteoarthritis. But also, regarding the ankylosing spondylitis in examination, there's a test which we usually do to add the value in the diagnosis. The test is called the Scober's test, whereby you draw the horizontal line in the two spines, superior iliac spine, and then you go above 10 centimeter. Then you tell the patient to bend forward and you measure again. There must be increase of more than 5, at least 5 centimeter. If there's less than 5 centimeter, then we can say probably the patient has got ankylosing spondylitis. So those are some few comments which I wanted to add. And thank you very much, presenter. It was very nice presentation to follow. Thank you.
Thank you very much, Doctor. It's unfortunate we are beyond the hour. I think we should close, but thank you very much. It shows you have a lot of knowledge concerning these rheum stuff. So good night, everyone, and thank you. We'll see you next week.
Good night.